DPH provides this copy of the regulation for the convenience of the public and makes every effort to ensure its accuracy. However, this is an unofficial version of the regulation. The regulation's most recent final publication in the South Carolina State Register presents the official, legal version of the regulation. Section 1200. Medication Management. General. 1. Medications, including controlled substances, medical supplies, and those items necessary for the rendering of first aid shall be available and properly managed in accordance with local, state, and federal laws and regulations. Such management shall address the securing, storing, and administering of medications, medical supplies, first aid supplies, and biologicals, their disposal when discontinued or outdated, and their disposition at discharge, death, or transfer of a resident. Medication Management. General. 1. Medications, including controlled substances, medical supplies, and those items necessary for the rendering of first aid shall be available and properly managed in accordance with local, state, and federal laws and regulations. Such management shall address the securing, storing, and administering of medications, medical supplies, first aid supplies, and biologicals, their disposal when discontinued or outdated, and their disposition at discharge, death, or transfer of a resident. Applicable reference materials published within the previous 3 years shall be available at the facility in order to provide staff members/volunteers with adequate information concerning medications. Medication and treatment orders. 1. Medications and treatments, to include oxygen, shall be administered to residents only upon orders, to include standing orders, of a physician or other authorized healthcare provider. Medications accompanying residents at admission may be administered to residents provided the medication is in the original labeled container and the order is subsequently obtained as a part of the admission physical examination. Should there be concerns regarding the appropriateness of administering medications due to the condition/state of the medication, e.g., expired, makeshift, or illegible labels, or the condition/state of health of the newly admitted resident, staff members shall consult with or make arrangements to have the resident examined by a physician or other authorized healthcare provider, or at the local hospital emergency room prior to administering any medications. All orders, including verbal orders, shall be received only by staff members authorized by the facility and shall be signed and dated by a physician or other authorized healthcare provider no later than 3 business days after the order is given. Medications and medical supplies ordered for a specific resident shall not be provided/administered to any other resident. Administering medications/treatments. 1. Doses of medication shall be administered by the same staff member who prepared them for administration. Preparation shall occur no earlier than 1 hour prior to administering. Preparation of doses for more than one scheduled administration shall not be permitted. Each physician-ordered treatment or medication dose administered/supervised shall be properly recorded by initialing on the resident's medication administration record, MAR, as the medication is administered or treatment record as treatment is rendered. Recording medication administration shall include medication name, dosage, mode of administration, date, time, and the signature of the individual administering or supervising the taking of the medication. If the ordered dosage is to be given on a varying schedule, e.g., take 2 tablets the first day and 1 tablet every other day by mouth with noon meal, the number of tablets shall also be recorded. The treatment record shall document the type of treatment, date and time of treatment, and signature of the individual administering treatment. Facility staff members may administer routine medications, acting in a surrogate family role, provided these staff members have been trained to perform these tasks in the proper manner by individuals licensed to administer medications. Facility staff members may administer injections of medications only in instances where medications are required for diabetes and conditions associated with anaphylactic reactions under established medical protocol. A staff licensed nurse may administer influenza and vitamin B12 injections and perform tuberculin skin tests. Although facility staff members may monitor blood sugar levels, provided she has been appropriately trained and the facility has received a certificate of waiver from Clinical Laboratories Improvement Amendments, CLA. The provision of sliding scale insulin injections by facility staff members is prohibited. Self-administering of medications by a resident is permitted only upon the specific written orders of the physician or other authorized healthcare provider, obtained on a semi-annual basis, or the facility shall ascertain by resident demonstration to the staff and document, at least quarterly, that she remains capable of self-administering medications. Facilities may elect not to permit self-administration. When residents who are unable to self-administer medications leave the facility for an extended period of time, the proper amount of medications, along with dosage, mode, date, and time of administration, shall be given to a responsible person who will be in charge of the resident during her absence from the facility. These details shall be properly documented in the march. In these instances, the amount of medication needed for the designated period of time may be transferred to a prescription vial or bottle that is properly labeled. At each shift change, there shall be a documented review of the MARs by outgoing staff members with incoming staff members that shall include verification by outgoing staff members that they have properly administered medications in accordance with orders by a physician or other authorized healthcare provider and have documented the administrations. Errors/omissions indicated on the MARs shall be addressed and corrective action taken at that time. Pharmacy services 1. Any pharmacy within the facility shall be provided by or under the direction of a pharmacist in accordance with accepted professional principles and appropriate local, state, and federal laws and regulations. Facilities which maintain stocks of legend drugs and biologicals for dispensing to residents shall obtain and maintain a valid, current pharmacy permit from the South Carolina Board of Pharmacy. Labeling of medications dispensed to residents shall be in compliance with local, state, and federal laws and regulations to include expiration date. Medication containers 1. Medications for residents shall be obtained from a permitted pharmacy or prescriber on an individual prescription basis. These medications shall bear a label affixed to the container which reflects at least the following: name of pharmacy, name of resident, name of the prescribing physician or other authorized healthcare provider, date and prescription number, directions for use, and the name and dosage unit of the medication. The label shall be brought into accord with the directions of the physician or other authorized healthcare provider each time the prescription is refilled. Medication containers having soiled, damaged, incomplete, illegible, or makeshift labels shall be returned to the pharmacy for relabeling or disposal. Residents may obtain their over-the-counter, OTC, medication from a pharmacy other than a pharmacy contracted with the facility. Medications for each resident shall be kept in the original containers, including unit dose systems. There shall be no transferring between containers, except in instances such as in Section 1203(e) above, or opening blister packs to remove medications for destruction or adding new medications for administration, except under the direction of a pharmacist. In addition, for those facilities that utilize the unit dose system or multi-dose system, an on-site review of the medication program by a pharmacist shall be conducted on at least a quarterly basis to ensure the program has been properly implemented and maintained. For changes in dosage, the new packaging shall be available in the facility no later than the next administration time subsequent to the order. If a physician or other authorized healthcare provider changes the dosage of a medication, a label, which does not obscure the original label, shall be attached to the container which indicates the new dosage, date, and prescriber's name. In lieu of this procedure, it is acceptable to attach a label to the container that states, "Directions changed. Refer to MAR and physician or other authorized healthcare provider orders for current administration instructions." The new directions shall be communicated to the pharmacist upon receipt of the order. Medication storage. 1. Medications shall be properly stored and safeguarded to prevent access by unauthorized persons. Expired or discontinued medications shall not be stored with current medications. Storage areas shall be locked and of sufficient size for clean and orderly storage. Storage areas shall not be located near sources of heat, humidity, or other hazards that may negatively impact medication effectiveness or shelf life. Medications requiring refrigeration shall be stored in a refrigerator at the temperature established by the U.S. Pharmacopoeia, 36 to 46 degrees Fahrenheit. Medications requiring refrigeration shall be kept in a secured refrigerator used exclusively for medications, or in a secured manner in which medications are separated from other items kept in a refrigerator, e.g. lockbox. All refrigerators storing medications shall have accurate thermometers within plus or minus 2 degrees. Medications shall be stored separately from poisonous substances or body fluids, in a manner which provides for separation between topical and oral medications and which provides for separation of each individual resident's medication. A facility shall maintain records of receipt, administration, and disposition of all controlled substances in sufficient detail to enable an accurate reconciliation, including separate control sheets on any controlled substances. This record shall contain the following information: date, time administered, name of resident, dose, signature of individual administering, name of physician or other legally authorized healthcare provider ordering the medication, and, at each shift change, a documented review of the control sheets by outgoing staff members with incoming staff members, including verification by outgoing staff members indicating they have properly administered medications in accordance with orders by a physician or other authorized healthcare provider and have documented the administrations. Errors/omissions indicated on the control sheets shall be addressed and corrective action taken at that time. Unless the facility has a permitted pharmacy, legend medications shall not be stored except those specifically prescribed for individual residents. Non-legend medications that can be obtained without a prescription may be retained and labeled as stock in the facility for administration as ordered by a physician or other authorized healthcare provider. The medications prescribed for a resident shall be protected from use by any other individuals. For those residents who have been authorized by a physician or other authorized healthcare provider to self-administer medications, such medications may be kept on the resident's person, i.e., a pocketbook, pocket, or any other method that would enable the resident to control the items. No medication shall be left in a resident's room unless the facility provides an individual cabinet/compartment which is kept locked in the room of each resident who has been authorized in writing to self-administer by a physician or other authorized healthcare provider. In lieu of a locked cabinet/compartment, storage of medications shall be permitted in a resident room which can be locked, provided the room is licensed for one bed. Medications are not accessible by unauthorized persons. The room is kept locked when the resident is not in the room. The medications are not controlled substances and all other requirements of this section are met. During nighttime hours in resident rooms, only medications which a physician or other authorized healthcare provider has ordered in writing for emergency/immediate use, e.g., nitroglycerin or inhalers, may be kept unlocked in or upon a cabinet or bedside table, and only when the resident to whom that medication belongs is present in the room. Disposition of medications. Upon discharge of a resident, the facility shall release unused medications to the resident, family member, or responsible party, as appropriate, and shall document the release with the signature of the person receiving the unused medications unless specifically prohibited by the attending physician or other authorized healthcare provider. Residents' medications shall be destroyed by the facility administrator or his/her designee when medication has deteriorated or exceeded its expiration date. Unused portions remain due to death or discharge of the resident or discontinuance of the medication may also be returned to the dispensing pharmacy. Medication that has been discontinued by order may be stored for a period not to exceed 30 days provided they are stored separately from current medications. The destruction of medication shall be witnessed by the administrator or his/her designee. the mode of destruction indicated, and these steps documented. Destruction records shall be retained by the facility for a period of 2 years. The destruction of controlled substances shall be accomplished only by the administrator or his or her designee and witnessed by the administrator or his or her designee and a staff member trained by individuals licensed to administer medications. Section 1300. Meal service. Section 1300. Meal service. General, 2. All facilities that prepare food on site shall be approved by the Department and shall be regulated, inspected, and graded pursuant to our .61-25. Facilities preparing food on site and licensed for 16 beds or more subsequent to the promulgation of these regulations shall have kitchen equipment, which meets the requirement of our .61-25. Existing facilities with 16 licensed beds or more may continue to operate with equipment currently in use. However, only certified/classified equipment shall be used when replacements are necessary. Those facilities with 15 beds or less shall be regulated pursuant to our .61-25 with certain exceptions in regard to food equipment, may utilize non-certified/non-classified food equipment. Exception. In facilities with 5 beds or less, in lieu of a 3-compartment sink, a non-certified/non-classified dishwasher may be used to wash equipment/utensils, provided the facility is equipped with at least a 2-compartment sink used to sanitize and adequately air-dry equipment/utensils. In facilities with 10 beds or less and licensed prior to May 24, 1991, as CRCFs, in which a 2-compartment sink serves to wash kitchen equipment/utensils. The facility shall provide an additional container of adequate length, width, and depth to completely immerse all equipment/utensils for final sanitation. Non-certified/non-classified dishwashers may be utilized in facilities licensed with 10 beds or less prior to May 24, 1991, provided they are approved by the Department. When meals are catered to a facility, such meals shall be obtained from a food service establishment graded by the Department, pursuant to our .61-25, and there shall be a written executed contract with the food service establishment. If food is prepared at a central kitchen and delivered to separate facilities or separate buildings and/or floors of the same facility, provisions shall be made and approved by the Department for proper maintenance of food temperatures and a sanitary mode of transportation. Food shall be palatable, properly prepared, and sufficient in quantity and quality to meet the daily nutritional needs of the residents in accordance with written dietary policies and procedures. Efforts shall be made to accommodate the religious, cultural, and ethnic preferences of each individual resident and consider variations of eating habits, unless the orders of a physician or other authorized healthcare provider contraindicate. Liquid or powder soap dispensers and sanitary paper towels shall be available at each food service hand wash lavatory. Alcohol-based waterless hand sanitizers shall not be used in lieu of liquid or powder soap. Food and food storage. Home canned food usage shall be prohibited. 1. At least a 1-week supply of staple foods and a 2-day supply of perishable foods shall be maintained on the premises. Supplies shall be appropriate to meet the requirements of the menu and special or therapeutic diets. 2. Meals and services. All facilities shall provide dietary services to meet the daily nutritional needs of the residents in accordance with the recommended dietary allowances of the Food and Nutrition Board of the National Research Council, National Academy of Sciences. 1. The dining area shall provide a congenial and relaxed environment. Table service shall be planned in an attractive and colorful manner for each meal and shall include full place settings with napkins, tablecloths or placemats, and non-disposable forks, spoons, knives, drink containers, plates, and other eating utensils/containers as needed. A minimum of 3 nutritionally adequate meals, in accordance with Section 1303A above, in each 24-hour period shall be provided for each resident unless otherwise directed by the resident's physician or other authorized healthcare provider. Not more than 14 hours shall elapse between the serving of the evening meal and breakfast the following day. 2. Special attention shall be given to preparation and prompt serving in order to maintain correct food temperatures for serving at the table or resident room, tray service. 2. The same foods shall not be repetitively served during each 7-day period except to honor specific, individual resident requests. Specific times for serving meals shall be established, documented on a posted menu, and followed. Suitable food and snacks shall be available and offered between meals at no additional cost to the residents. 2. Residents shall be encouraged to eat in the dining room at mealtime. Tray service shall be permitted when the resident is medically unable to access the dining area for meals, or if the facility has received written notice from the resident/responsible party of a preference to receive tray service, in which case it may be provided on an occasional basis unless otherwise indicated in the facility's policies and procedures. Under no circumstances may staff members utilize tray service for their own convenience. 2. Meal service personnel. 2. Sufficient staff members/volunteers shall be available to serve food and to provide individual attention and assistance as needed. Dietary services shall be organized with established lines of accountability and clearly defined job assignments for those engaged in food preparation and serving. There shall be trained staff members/volunteers to supervise the preparation and serving of the proper diet to the residents, including having sufficient knowledge of food values in order to make appropriate substitutions when necessary. The facility shall not permit residents to engage in food preparation. Exception: a resident may engage in food preparation provided the following criteria are met. Approval to engage in food preparation by a physician or other authorized medical authority. The ICP of the resident has indicated food preparation as suitable/beneficial to the resident. The resident is directly supervised by staff members/volunteers, must be in the kitchen with the resident. Preparing food must be part of an organized program in which daily living skills are being taught. The utilization of residents for preparing food is not a substitute for staff members/volunteers. Diets. If the facility accepts or retains residents in need of medically prescribed special diets, the menus for such diets shall be planned by a professionally qualified dietitian or shall be reviewed and approved by a physician or other authorized healthcare provider. The facility shall maintain documentation that each of these menus has been planned by a dietitian, a physician, or other authorized healthcare provider. At a minimum, documentation for each resident's special diet menu shall include the signature of the dietitian, the physician or other authorized healthcare provider, his/her title, and the date he/she signed the menu. The facility shall maintain staff capable of the preparation/serving of any special diet, e.g., low sodium, low fat, 1,200 calorie, diabetic diet. Facility staff preparing a resident's special diet shall be knowledgeable of the procedure to prepare each special diet. The preparation of any resident's special diet shall follow the written guidance provided by a registered dietitian, physician, or other authorized healthcare provider authorizing the resident's special diet. For each resident receiving a special diet, this written guidance shall be documented in the resident's record. 1. If special diets are required, the necessary equipment for preparation of those diets shall be available and utilized. A diet manual published within the previous 5 years shall be available and shall address at minimum food sources and food quality, food protection storage, preparation and service, food worker health and cleanliness, recommended dietary allowances of the Food and Nutrition Board of the National Research Council, National Academy of Sciences food serving recommendations, general menu planning. Menu planning appropriate to special needs, e.g., diabetic, low salt, low cholesterol, or other diets appropriate for the elderly and/or infirmed. Menus. Menus shall be planned and written at a minimum of 1 week in advance and dated as served. The current week's menu, including routine and special diets and any substitutions or changes made, shall be readily available and posted in one or more conspicuous places in a public area. All substitutions made on the master menu shall be recorded in writing. Cycled menus shall be rotated so that the same weekly menu is not duplicated for at least a period of 3 weeks. Records of menus as served shall be maintained for at least 30 days. Ice and drinking water. 2. Ice from a water system that is in accordance with our .61-58 shall be available and precautions taken to prevent contamination. The ice scoop shall be stored in a sanitary manner outside of the ice container. Portable drinking water shall be available and accessible to residents at all times. The usage of common cups shall be prohibited. Ice delivered to resident areas in bulk shall be in non-porous, covered containers that shall be cleaned after each use. Section 1400. Section 1400. Emergency procedures/disaster preparedness. Disaster preparedness. 2. All facilities shall develop, by contact and consultation with their county emergency preparedness agency, a suitable written plan for actions to be taken in the event of a disaster and/or emergency evacuation, and implement the written plan for actions at the time of need. Prior to initial licensing of a facility, the completed plan shall be submitted to the department for review. Additionally, in instances where there are applications for increases in licensed bed capacity, the emergency and disaster evacuation plan shall be updated to reflect the proposed new total licensed bed capacity. All staff members and volunteers shall be made familiar with this plan and instructed as to any required actions. A copy of the emergency and disaster evacuation plan shall be available for inspection by the resident and/or responsible party upon request. The emergency and disaster evacuation plan shall be reviewed and updated annually as appropriate. Staff members shall rehearse the emergency and disaster evacuation plan at least annually and shall not require resident participation. The disaster/emergency evacuation plan shall include, but not be limited to, a sheltering plan to include the licensed bed capacity and average occupancy rate, name, address, and phone number of the sheltering facility, IS, to which the residents will be relocated during a disaster. A letter of agreement signed by an authorized representative of each sheltering facility which shall include the number of relocated residents that can be accommodated, sleeping, feeding, and medication plans for the relocated residents, and provisions for accommodating relocated staff members/volunteers. The letter shall be updated with the sheltering facility at least every 3 years and whenever significant changes occur. For those facilities located in Beaufort, Charleston, Colleton, Horry, Jasper, and Georgetown counties, at least one sheltering facility shall be located in a county other than these counties. A transportation plan to include agreements with entities for relocating residents, which addresses number and type of vehicles required, how and when the vehicles are to be obtained, who, by name or organization, will provide drivers, procedures for providing appropriate medical support, food, water, and medications during transportation and relocation based on the needs and number of the residents. Estimated time to accomplish the relocation. Primary and secondary routes to be taken to the sheltering facility. A staffing plan for the relocated residents to include how care will be provided to the relocated residents, including the number and type of staff members that will accompany residents who are relocated. Prearranged transportation arrangements to ensure staff members are relocated to the sheltering facility. Cosigned statement by an authorized representative of the sheltering facility if staffing is to be provided by the sheltering facility. Emergency call numbers. Emergency call data shall be posted in a conspicuous place and shall include at least the telephone numbers of fire and police departments, ambulance service, and the Poison Control Center. Other emergency call information shall be available to include the names, addresses, and telephone numbers of staff members/volunteers to be notified in case of emergency. Continuity of essential services, 2. There shall be a written plan to be implemented to assure the continuation of essential resident support services for such reasons as power outage, water shortage, or in the event of the absence from work of any portion of the workforce resulting from inclement weather or other causes. Section 1500. Section 1500. Fire prevention. Arrangements for fire department response/protection. 1. Each facility shall develop, in coordination with its supporting fire department and/or disaster preparedness agency, suitable written plans for actions to be taken in the event of fire, i.e., fire plan and evacuation plan. Facilities located outside of a service area or range of a public fire department shall arrange for the nearest fire department to respond in case of fire by written agreement with that fire department. A copy of the agreement shall be kept on file in the facility and a copy shall be forwarded to the department. If the agreement is changed, a copy shall be forwarded to the department. Tests and inspections. 1. Fire protection and suppression systems shall be maintained and tested in accordance with the provisions of the codes officially adopted by the South Carolina Building Codes Council and the South Carolina State Fire Marshal applicable to community residential care facilities. Fire response training. 1. Fire response training shall address at a minimum the following. Fire plan, including the training of staff members/volunteers. Reporting of fire. Use of the fire alarm system if applicable. Location and use of firefighting equipment. Methods of fire containment. Specific responsibilities, tasks, or duties of each individual. A plan for the evacuation of residents, staff members, and visitors to include evacuation routes and procedures in case of fire or other emergencies shall be established and posted in conspicuous public areas throughout the facility. All residents capable of assisting in their evacuation shall be trained in the proper actions to take in the event of a fire, e.g., actions to take if the primary escape route is blocked. Residents shall be made familiar with the fire plan and evacuation plan upon admission, and a copy of the evacuation floor diagram shall be provided to each resident and/or the resident's responsible party. Fire drills. 1. An unannounced fire drill shall be conducted at least quarterly for all shifts. Each staff member/volunteer shall participate in a fire drill at least once each year. Records of drills shall be maintained at the facility, indicating the date, time, shift, description, and evaluation of the drill, and the names of staff members/volunteers and residents directly involved in responding to the drill. If fire drill requirements are mandated by statute or regulation, then provisions of the statute or regulation shall be complied with and shall supersede the provisions of Section 1504. Drills shall be designed and conducted in consideration of and reflecting the content of the fire response training described in Section 1503 above. All residents shall participate in fire drills. In instances when a resident refuses to participate in a drill, efforts shall be made to encourage participation, e.g., counseling, implementation of incentives rewarding residents for participation. Specific staff/volunteer to resident assignments to promote resident participation. Continued refusal may necessitate implementation of the discharge planning process to place the resident in a setting more appropriate to their needs and abilities. In conducting fire drills, all residents shall evacuate to the outside of the building to a selected assembly point. Drills shall be designed to ensure that residents attain the experience of exiting through all exits. Section 1600. Maintenance. 1601. General. 2. The facility shall keep all equipment and building components, e.g., doors, windows, lighting fixtures, plumbing fixtures, in good repair and operating condition. The facility shall document preventive maintenance. The facility shall comply with the provisions of the codes officially adopted by the South Carolina Building Codes Council and the South Carolina State Fire Marshal applicable to community residential care facilities. Section 1700. Infection Control and Environment. Staff Practices 1. Staff/volunteer practices shall promote conditions that prevent the spread of infectious, contagious, or communicable diseases and provide for the proper disposal of toxic and hazardous substances. These preventive measures/practices shall be in compliance with applicable guidelines of the Blood-Borne Pathogens Standard of the Occupational Safety and Health Act, OSHA, of 1970, the Centers for Disease Control and Prevention, CDC, and are .61-105, and other applicable federal, state, and local laws and regulations. Tuberculin skin testing 1. Tuberculin skin testing is a diagnostic tool for detecting tuberculosis infection. A small dose, 0.1 ml, of purified protein derivative, PPD, tuberculin is injected just beneath the surface of the skin by the intradermal Mantoux method, and the area is examined for induration, hard, dense, raised area at the site of the TST administration, 48 to 72 hours after the injection, but positive reactions can still be measurable up to a week after administering the TST. The size of the indurated area is measured with a millimeter ruler, and the reading is recorded in millimeters, including 0 mm to represent no induration. Redness/erythema is insignificant and is not measured or recorded. Authorized healthcare providers are permitted to perform tuberculin skin testing and symptom screening. All facilities shall conduct an annual tuberculosis risk assessment, see Section 101, BBB, in accordance with CDC guidelines, see Section 102, B.16. to determine the appropriateness and frequency of tuberculosis screening and other tuberculosis-related measures to be taken. The risk classification, i.e., low risk, medium risk, shall be used as part of the risk assessment to determine the need for an ongoing TB screening program for staff/direct care volunteers and residents and the frequency of screening. A risk classification shall be determined for the entire facility. In certain settings, e.g., healthcare organizations that encompass multiple sites or types of services, specific areas defined by geography, functional units, patient population, job type, or location within the setting may have separate risk classifications. Staff/direct care volunteers/private sitters tuberculin skin testing. Tuberculosis status. Prior to date of hire or initial resident contact, the tuberculosis status of staff/direct care volunteers/private sitters shall be determined in the following manner in accordance with the applicable risk classification. Low risk. Baseline two-step tuberculin skin test, TST, or a single blood assay for Mycobacterium tuberculosis, BMT, all staff/direct care volunteers/private sitters within 3 months prior to contact with residents, unless there is a documented TST or a BMT result during the previous 12 months. If a newly employed staff/direct care volunteer or private sitter has had a documented negative TST or a BMT result within the previous 12 months, a single TST or the single BMT can be administered and read to serve as the baseline prior to resident contact. Periodic TST or BMT is not required. Post-exposure TST or a BMT for staff/direct care volunteers upon unprotected exposure to tuberculosis. Perform a contact investigation when unprotected exposure is identified. Administer 1 TST or a BMT as soon as possible to all staff who have had unprotected exposure to an infectious TB case/suspect. If the TST or the BMT result is negative, administer another TST or a BMT 8 to 10 8 to 10 weeks after that exposure to M. tuberculosis ended. Post-exposure TST or a BMT for private sitters upon unprotected exposure to M. tuberculosis. Written evidence of a contact investigation when unprotected exposure is identified shall be provided to the facility administrator. The private sitter shall provide documentation of a completed single TST or a BMT prior to resident contact. If the TST or BMT result is negative, the private sitter shall provide written evidence of an additional TST or BMT 8 to 10 weeks after that exposure to M. tuberculosis ended. CDC Guidelines for Preventing the Transmission of Mycobacterium tuberculosis in Healthcare Settings, December 30, 2005. Baseline positive with or without documentation of treatment for latent TB infection, LTBI, see Section 101. BB or TB disease shall have a symptom screen prior to employment and annually thereafter. Upon hire, staff/direct care volunteers/private sitters with a newly positive test result for M. tuberculosis infection, i.e., TST or BMT, or signs or symptoms of tuberculosis, e.g., cough, weight loss, night sweats, fever, shall have a chest radiograph performed immediately to exclude TB disease, or evaluate an interpretable copy taken within the previous 3 months. Repeat radiographs are not needed unless symptoms or signs of TB disease develop or unless recommended by a physician. These staff members/direct care volunteers/private sitters will be evaluated for the need for treatment of TB disease or latent TB infection, LTBI, and will be encouraged to follow the recommendations made by a physician with TB expertise, i.e., the department's TB control program. Medium risk. Baseline two-step TST or a single BMT. All staff/direct care volunteers/private sitters within 3 months prior to contact with residents, unless there is a documented TST or a BMT result during the previous 12 months. If a newly employed staff/direct care volunteer/private sitter has had a documented negative TST or a BMT result within the previous 12 months, a single TST or the single BMT can be administered to serve as the baseline prior to resident contact. Periodic testing with TST or BMT annually of all staff/direct care volunteers who have risk of TB exposure and who have previous documented negative results. Instead of participating in periodic testing, staff/direct care volunteers with documented TB infection, positive TST or BMT, shall receive a symptom screen annually. This screen shall be accomplished by educating the staff/direct care volunteers who have documented TB infection about symptoms of TB disease, including the staff's and/or direct care volunteers' responses concerning symptoms of TB disease. Documenting the questioning of the staff/direct care volunteers about the presence of symptoms of TB disease, and instructing the staff/direct care volunteers to report any such symptoms immediately to the administrator. Treatment for latent TB infection, LTBI, shall be considered in accordance with CDC and department guidelines, and, if recommended, treatment completion shall be encouraged. Periodic testing with TST or BMT annually of all private sitters who have risk of TB exposure and who have previous documented negative results. Instead of participating in periodic testing, private sitters with documented TB infection, positive TST or BMT, shall provide the facility with written evidence of a symptom screen annually. Documentation of education about symptoms of TB disease, including responses concerning symptoms of TB disease, and written evidence of the questioning about the presence of symptoms of TB disease, and the report of any such symptoms shall be provided immediately to the facility administrator. Post-exposure TST or a BMT for staff/direct care volunteers upon unprotected exposure to M. tuberculosis, perform a contact investigation. See Section 101 M. When unprotected exposure is identified. Administer 1. TST or a BMT as soon as possible to all staff/direct care volunteers/private sitters who have had unprotected exposure to an infectious TB case/suspect. If the TST or the BMT result is negative, administer another TST or BMT 8 to 10 weeks after that exposure to M. tuberculosis ended. Post-exposure TST or a BMT for private sitters upon unprotected exposure to M. tuberculosis. Written evidence of a contact investigation when unprotected exposure is identified shall be provided to the facility administrator. The private sitter shall provide documentation of a completed single TST or a BMT prior to resident contact. If the TST or BMT result is negative, the private sitter shall provide written evidence of an additional TST or BMT 8 to 10 weeks after that exposure to M. Tuberculosis ended. Baseline positive or newly positive test result. Baseline positive with or without documentation of treatment for latent TB infection, LTBI, or TB disease shall have a symptom screen prior to employment and annually thereafter. Upon hire, staff/direct care volunteers/private sitters with a newly positive test result for M. tuberculosis infection, i.e., TST or BMT, or signs or symptoms of tuberculosis, e.g., cough, weight loss, night sweats, fever, shall have a chest radiograph performed immediately to exclude TB disease, or evaluate an interpretable copy taken within the previous 3 months. Repeat chest radiographs are not required unless symptoms or signs of TB disease develop or unless recommended by a physician. These staff members/direct care volunteers/private sitters will be evaluated for the need for treatment of TB disease or latent TB infection, LTBI, and will be encouraged to follow the recommendations made by a physician with TB expertise, i.e., the department's TB control program. Staff/direct care volunteers/private sitters who are known or suspected to have TB disease shall be excluded from work, required to undergo evaluation by a physician, and permitted to return to work only with written approval by the department's TB control program. Repeat chest radiographs are not required unless symptoms or signs of TB disease develop or unless recommended by a physician. Resident tuberculosis screening 1. Tuberculosis status. Prior to admission, the tuberculosis status of a resident shall be determined in the following manner in accordance with the applicable risk classification. For low risk and medium risk, admission/baseline 2-step TST or a single BMT, all residents within 30 days prior to admission shall have completed the first step of the 2-step tuberculin skin test followed 7 to 21 days later by a second test unless there is a documented TST or a BMT result during the previous 12 months. If a newly admitted resident has had a documented negative TST or a BMT result within the previous 12 months, a single TST or the single BMT can be administered within 1 month prior to admission to the facility to serve as the baseline. As an exception, a resident may be admitted with at least the first step of the TB screening process completed prior to admission and the second step within 14 days of admission. Periodic TST or BMT is not required. Post-exposure TST or a BMT for residents upon unprotected exposure to M. tuberculosis. Perform a contact investigation when unprotected exposure is identified. Administer 1 TST or a BMT as soon as possible to all residents who have had exposure to an infectious TB case/suspect. If the TST or the BMT result is negative, administer another TST or a BMT 8 to 10 weeks after that exposure to M. tuberculosis ended. Baseline positive or newly positive test result. Residents with a baseline positive or newly positive test result for M. tuberculosis infection, i.e., TST or BMT, or documentation of treatment for latent TB infection, LTBI, or TB disease or signs or symptoms of tuberculosis, e.g., cough, weight loss, night sweats, fever, shall have a chest radiograph performed immediately to exclude TB disease, or evaluate an interpretable copy taken within the previous 3 months. Routine repeat chest radiographs are not required unless symptoms or signs of TB disease develop or unless recommended by a physician. These residents shall be evaluated for the need for treatment. If diagnosed with latent TB infection, LTBI, the resident shall be encouraged to follow the recommendations made by a physician with TB expertise, i.e., the department's TB control program. For those residents diagnosed with TB disease, the facility shall assure that the affected residents follow the recommendations made by a physician with TB expertise, i.e., the department's TB control program. Residents who are known or suspected to have TB disease shall be transferred from the facility if the facility does not have an airborne infection isolation room, see Section 101(e), required to undergo evaluation by a physician, and permitted to return to the facility only with written approval by the department's TB control program. Individuals who have been declared in writing to be in an emergency crisis stabilization status may be admitted to the facility without the initial step of the two-step tuberculin skin test or while awaiting the result of a BMT. These individuals shall be placed in an area separate from the general population. This admission to the facility may be made provided there is documentation at the facility of the declaration by Adult Protective Services of the South Carolina Department of Social Services or the South Carolina Department of Mental Health that the admission is, in fact, an emergency. Note: only these agencies may declare these crisis stabilization admissions to be an emergency. There is written evidence of a chest X-ray within 1 month prior to admission and a written assessment by a physician or other authorized healthcare provider that there is no active TB and a negative assessment for signs and/or symptoms of tuberculosis, and the resident will receive the initial step of the two-step tuberculin test within 24 hours of admission to the facility. The second step of the two-step tuberculin skin test must be administered within the next 7 to 14 days. Housekeeping 2. Housekeeping 2. The facility and its grounds shall be clean and free of vermin and offensive odors. Interior housekeeping shall at a minimum include cleaning each specific area of the facility, cleaning and disinfection as needed of equipment used and/or maintained in each area appropriate to the area and the equipment's purpose or use, safe storage of chemicals indicated as harmful on the product label, cleaning materials and supplies in cabinets or well-lighted closets/rooms inaccessible to residents. If a physician or other authorized healthcare provider has determined that a resident is capable of appropriately using a cleaning product or other hazardous agent, the facility may elect to permit the resident to use the product, provided there is a written statement from a physician or other authorized healthcare provider that assures that the resident is capable of maintaining the product in a secure locked manner and that a description of product usage is outlined in the resident's ICP. Exterior housekeeping shall at a minimum include cleaning of all exterior areas, e.g., porches and ramps, and removal of safety impediments such as snow and ice. Keeping facility grounds free of weeds, rubbish, overgrown landscaping, and other potential breeding sources for vermin. Safe storage of chemicals indicated as harmful on the product label, equipment, and supplies inaccessible to residents. Infectious waste 1. Accumulated waste, including all contaminated sharps, dressings, and/or similar infectious waste, shall be disposed of in a manner compliant with OSHA bloodborne pathogens standard and are .61, 105. Pets 2. If the facility chooses to permit pets, healthy animals that are free of fleas, ticks, and intestinal parasites and have been screened by a veterinarian prior to resident contact, have received required inoculations, if applicable, and that present no apparent threat to the health, safety, and well-being of the residents, may be permitted in the facility, provided they are sufficiently fed and cared for and that both the pets and their housing are kept clean. Pets shall not be allowed near residents who have allergic sensitivities to pets, or for other reasons such as residents who do not wish to have pets near them. Pets shall not be allowed in the kitchen area. Pets shall be permitted in resident dining areas only during times when food is not being served. If the dining area is adjacent to a food preparation or storage area, those areas shall be effectively separated by walls and closed doors while pets are present. If personal pets are permitted in the facility, the housing of those pets shall be either in a resident private room or outside the facility. Clean/soiled linen and clothing. 2. Clean linen/clothing. A supply of clean, sanitary linen/clothing shall be available at all times. In order to prevent the contamination of clean linen/clothing by dust or other airborne particles or organisms, clean linen/clothing shall be stored and transported in a sanitary manner, e.g., enclosed and covered. Linen/clothing storage rooms shall be used only for the storage of linen/clothing. Clean linen/clothing shall be separated from storage of other purposes. Soiled linen/clothing. Soiled linen/clothing shall neither be sorted, rinsed, nor washed outside of the laundry service area. Provisions shall be made for collecting, transporting, and storing soiled linen/clothing. Soiled linen/clothing shall be kept in enclosed/covered containers. Laundry operations shall not be conducted in resident rooms, dining rooms, or in locations where food is prepared, served, or stored. Freezers/refrigerators may be stored in laundry areas, provided sanitary conditions are maintained. Exception: residents may sort, rinse/hand wash their own soiled, delicate, personal items, e.g., pantyhose, underwear, socks, handkerchiefs, clothing, accessories, heirloom linens, needlepoint, crocheted, or knitted pillows or pillowcases, or other similar items personally owned and cared for by the resident, in a private bathroom sink, provided the practice does not create a safety hazard, e.g., water on the floor. Section 1800. Quality Improvement Program. 1801. General. 2. There shall be a written, implemented quality improvement program that provides effective self-assessment and implementation of changes designed to improve the care/services provided by the facility. The quality improvement program, as a minimum, shall establish desired outcomes and the criteria by which policy and procedure effectiveness is regularly, systematically, and objectively accomplished. Identify, evaluate, and determine the causes of any deviation from the desired outcomes. Identify the action taken to correct deviations and prevent future deviation and the persons responsible for implementation of these actions. Analyze the appropriateness of ICPs and the necessity of care/services rendered. Analyze all incidents and accidents to include all medication errors and resident deaths. Analyze any infection, epidemic outbreaks, or other unusual occurrences which threaten the health, safety, or well-being of the residents. Establish a systematic method of obtaining feedback from residents and other interested persons, e.g., family members and peer organizations, as expressed by the level of satisfaction with care/services received. Section 1900. Design and Construction. General. 2. Facilities shall be planned, designed, and equipped to provide and promote the health, safety, and well-being of each resident. Facility design shall be such that all residents have access to required services. There shall be at least 200 gross square feet per licensed bed in facilities with 10 beds or less, and in facilities licensed for more than 10 beds, at least an additional 100 gross square feet per licensed bed. Codes and Standards. 2. Facility design and construction shall comply with provisions of the codes officially adopted by the South Carolina Building Codes Council and the South Carolina State Fire Marshal applicable to community residential care facilities. Unless specifically required otherwise by the department, All facilities shall comply with the construction codes and construction regulations applicable at the time its license was issued. Submission of plans 2. Plans and specifications shall be submitted to the Department for review and approval for new construction, additions or alterations to existing buildings, replacement of major equipment, buildings being licensed for the first time, buildings changing license type, and for facilities increasing occupant load or licensed capacity. Final plans and specifications shall be prepared by an architect and/or engineer registered in South Carolina and shall bear their seals and signatures. Architectural plans shall also bear the seal of a South Carolina registered architectural corporation. Unless directed otherwise by the department, submit plans at the schematic, design development, and final stages. All plans shall be drawn to scale with the title, stage of submission, and date shown thereon. Any construction changes from the approved documents shall be approved by the department. Construction work shall not commence until a plan approval has been received from the department. During construction, the owner shall employ a registered architect and/or engineer for observation and inspections. The department shall conduct periodic inspections throughout each project. Plans and specifications shall be submitted to the department for review and approval for projects that have an effect on the function of a space, the accessibility to or of an area, the structural integrity of the facility, the active and/or passive fire safety systems, including kitchen equipment such as exhaust hoods or equipment required to be under an exhaust hood, doors, walls, ceiling system assemblies, exit corridors, life safety systems, or that increase the occupant load or licensed capacity of the facility. All subsequent addenda, change orders, field orders, and documents altering the department review must be submitted. Any substantial deviation from the accepted documents shall require written notification, review, and reapproval from the department. Cosmetic changes utilizing paint, wall covering, floor covering, etc. that are required to have a flame spread rating or to satisfy other safety criteria shall be documented with copies kept on file at the facility and made available to the department. Inspections. Construction work which violates codes or standards will be required to be brought into compliance. All projects shall obtain all required permits from the locality having jurisdiction. Construction without proper permitting shall not be inspected by the department. Section 2000. Fire Protection, Prevention, and Life Safety 1. 2001. Alarms. Facilities with 6 or more licensed beds shall have a partial, manual, automatic, supervised fire alarm system. The facility shall arrange the system to transmit an alarm automatically to a third party. The alarm system shall notify by audible and visual alarm all areas and floors of the building. The alarm system shall shut down central recirculation systems and outside air units that serve the areas of alarm origination as a minimum. All fire, smoke, heat, sprinkler flow, and manual fire alarming devices must be connected to and activate the main fire alarm system when activated. Section Section 2100. General construction requirements. Floor finishes 2. Floor coverings and finishes shall meet the requirements of the building codes. All floor coverings and finishes shall be appropriate for use in each area of the facility and free of hazards, e.g., slippery surfaces. Floor finishes shall be composed of materials that permit frequent cleaning and, when appropriate, disinfection. Wall finishes 1. Wall finishes shall meet the requirements of the building codes. Manufacturer's certifications or documentation of treatment for flame spread and other safety criteria shall be furnished and maintained. Curtains and draperies 2. In bathrooms and resident rooms, Window treatments shall be arranged in a manner to provide privacy. Gases 1. Safety precautions shall be taken against fire and other hazards when oxygen is dispensed, administered, or stored. No smoking, signs shall be posted conspicuously, and cylinders shall be properly secured in place. Smoking shall be allowed only in designated areas in accordance with the facility smoking policy. No smoking is permitted in resident rooms or staff bedrooms or bath/restrooms. Furnishings/equipment. 1. The facility shall maintain the physical plant to be free of fire hazards or impediments to fire prevention. No portable electric or unvented fuel heaters shall be permitted in the facility. Fireplaces and fossil fuel stoves, e.g., wood burning, shall have partitions or screens or other means to prevent burns. Fireplaces shall be vented to the outside. Unvented type gas logs are not allowed. Gas fireplaces shall have a remote gas shutoff within the room and not inside the fireplace. Waste baskets, window dressings, cubicle curtains, mattresses, and pillows shall be non-combustible, inherently flame-resistant, or treated or maintained flame-resistant. Section 2200. Exits. 2201. Number and locations of exits. 1. The facility shall maintain halls, corridors, and all other means of egress from the building to be free of obstructions. Waste baskets, window dressings, cubicle curtains, mattresses, and pillows shall be non-combustible. Each resident room shall open directly to an approved exit access corridor without passage through another occupied space, or shall have an approved exit directly to the outside at grade level and accessible to a public space free of encumbrances. Exception: when two resident rooms share a common, sitting, area that opens onto the exit access corridor. Section 2300. Water supply/hygiene. Design and construction. 2. Resident and staff hand-washing lavatories and resident showers/tubs shall be supplied with hot and cold water at all times. Plumbing fixtures that require hot water and are accessible to residents shall be supplied with water that is thermostatically controlled to a temperature of at least 100 degrees Fahrenheit and not to exceed 120 degrees Fahrenheit. At the fixture, the water heater or combination of heaters shall be sized to provide at least 6 gallons per hour per bed at the above temperature range. 2. Hot water supplied to the kitchen equipment/utensil washing sink shall be supplied at 120 degrees Fahrenheit, provided all kitchen equipment/utensils are chemically sanitized. For those facilities sanitizing with hot water, the sanitizing compartment of the kitchen equipment/utensil washing sink shall be capable of maintaining the water at a temperature of at least 180 degrees Fahrenheit. Hot water provided for washing linen/clothing shall not be less than 160 degrees Fahrenheit. Should chlorine additives or other chemicals which contribute to the margin of safety in disinfecting linen/clothing be a part of the washing cycle, the minimum hot water temperature shall not be less than 110 degrees Fahrenheit, provided hot air drying is used. 2. Cross connections. 1. There shall be no cross connections in plumbing between safe and potentially unsafe water supplies. Water shall be delivered at least 2 delivery pipe diameters above the rim or points of overflow to each fixture, equipment, or service unless protected against back siphonage by approved vacuum breakers or other approved backflow preventers. A faucet or fixture to which a hose may be attached shall have an approved vacuum breaker or other approved backflow preventer. Section 2400. Electrical. Receptacles. 2. Resident room. Each resident room shall have duplex grounding type receptacles located to include one at the head of each bed. Corridors. Duplex receptacles for general use shall be installed approximately 50 feet apart in all corridors and within 25 feet of the ends of corridors. Ground fault protection. 1. Ground fault circuit interrupter protection shall be provided for all outside receptacles and bathrooms. The facility shall provide ground fault circuit interrupter protection for any receptacles within 6 feet of a sink or any other wet location. If the sink is an integral part of the metal splash board grounded by the sink, the entire metal area is considered part of the wet location. Exit signs. 1. In facilities licensed for 6 or more beds, required exits and ways to access thereto shall be identified by electrically illuminated exit signs. Changes in egress direction shall be marked with exit signs with directional arrows. Exit signs in corridors shall be provided to indicate 2 directions of exit. Emergency electric service. 1. Emergency electric services shall be provided as follows. Exit lights, if required. Exit access corridor lighting. Illumination of means of egress. Fire detection and alarm systems, if required. Section 2500. 2500. Section 2500. Heating, ventilation, and air conditioning. 2501. General. 2. The HVAC system shall be inspected at least once a year by a certified/licensed technician. The facility shall maintain a temperature of between 72 and 78 degrees Fahrenheit in resident areas. No HVAC supply or return grill shall be installed within 3 feet of a smoke detector. 1. HVAC grills shall not be installed in floors. Intake air ducts shall be filtered and maintained to prevent the entrance of dust, dirt, and other contaminating materials. The system shall not discharge in such a manner that would be an irritant to the residents/staff/volunteers. All kitchen areas shall be adequately ventilated in order for all areas to be kept free from excessive heat, steam, condensation, vapors, smoke, and fumes. Each bath/restroom shall have either operable windows or have approved mechanical ventilation. Section 2600. Physical plant. Facility accommodations/floor area. 2. Consideration shall be given to the preferences of the residents in determining an appropriate home-like atmosphere in resident rooms and activities/dining areas. There shall be sufficient living arrangements providing for residents quiet reading, study, relaxation, entertainment, or recreation, to include living, dining, and recreational areas available for residents' use. Minimum square footage requirements shall be as follows. 2. 20 square feet per licensed bed of living and recreational areas combined, excluding bedrooms, halls, kitchens, dining rooms, bathrooms, and rooms not available to the residents. 15 square feet of floor space in the dining area per licensed bed. All required care/services furnished at the facility shall be provided in a manner which does not require residents to ambulate from one site to another outside the buildings, nor which impedes residents from ambulating from one site to another due to the presence of physical barriers. Methods for ensuring visual and auditory privacy between resident and staff/volunteers/visitors shall be provided as necessary. Resident rooms. A resident shall have the choice to furnish his/her room. Whether the resident or the facility furnishes the room, each resident room shall be equipped with the following as a minimum for each resident. A comfortable single bed having a mattress with moisture-proof cover, sheets, blankets, bedspread, pillow and pillowcases, rollaway type beds, cots, bunk beds, and folding beds shall not be used. It is permissible to remove a resident bed and place the mattress on a platform or pallet or use a recliner provided the physician or other authorized healthcare provider has approved and the decision is documented in the ICP. 2. Exception. In the case of a married couple sharing the same room, a double bed is permitted if requested. For all other requirements, this shall be considered a bedroom with 2 beds. a closet or wardrobe, a bureau consisting of at least 3 drawers, and a compartmentalized bedside table/nightstand to adequately accommodate each resident's personal clothing, belongings, and toilet articles. Built-in storage is permitted. Exception: in existing facilities, if square footage is limited, residents may share these storage areas. However, specific spaces within these storage areas shall be provided by the facility particular to each resident. A comfortable chair for each resident occupying the room. In facilities licensed prior to the promulgation of this regulation, if the available square footage of the resident room will not accommodate a chair for each resident, or if the provision of multiple chairs impedes resident ability to freely and safely move about within their room, at least one chair shall be provided by the facility and provisions made to have additional chairs available for temporary use in the resident's room by visitors. If hospital-type beds are used, there shall be at least 2 lockable casters on each bed, located either diagonally or on the same side of the bed. Beds shall not be placed in corridors, solaria, or other locations not designated as resident room areas. 1. No resident room shall contain more than 3 beds. 2. No resident room shall be located in a basement. Access to a resident room shall not be by way of another resident room, toilet, bathroom, or kitchen. Equipment such as bedpans, urinals, and hot water bottles necessary to meet resident needs shall be provided by the facility. Portable commodes shall be permitted in resident rooms only at night or in case of temporary illness and suitably stored at all other times. 2. Exception: permanent positioning of a portable commode at bedside shall only be permitted if the room is private, the commode is maintained in a sanitary condition, and the room is of sufficient size to accommodate the commode. Side rails may be utilized when required for safety and when ordered by a physician or other authorized healthcare provider. When there are special concerns, e.g., residents with dementia, side rail usage shall be monitored by staff members as per facility policies and procedures. 1. In semi-private rooms, when personal care is being provided, arrangements shall be made to ensure privacy, e.g., portable partitions or cubicle curtains when needed or requested by a resident. There shall be at least one mirror in each resident room or resident bathroom. As an exception, when a resident's condition is such that having a mirror may be detrimental to his/her well-being, e.g., agitation and confusion associated with dementia, mirrors are not required. Consideration shall be given to resident compatibility in the assignment of rooms for which there is multiple occupancy. At least one private room shall be available in the facility in order to provide assistance in addressing resident compatibility issues, resident preferences, and accommodations for residents with communicable disease. Resident room floor area. Each resident room shall be an outside room with an outside window or door. 1. In non-apartment units, the resident sleeping room floor area is a usable or net area and does not include wardrobes, built-in or freestanding closets, or the entry alcove to the room. The following is the minimum floor space allowed. 2. Rooms for only one resident, 100 square feet. Rooms for more than one resident, 80 square feet per resident. Resident sleeping rooms shall be of sufficient size to allow 3 feet between 2 beds. 2. Bathrooms/restrooms. 2. Separate bathroom facilities shall be provided for live-in staff members/volunteers/public and/or family. Toilets shall be provided in ample number to serve the needs of staff members/volunteers/public. The minimum number for residents shall be 1 toilet for each 6 licensed beds or fraction thereof. There shall be at least one hand-wash lavatory adjacent to each toilet. Liquid soap shall be provided in public restrooms and bathrooms used by more than one resident. Communal use of bar soap is prohibited. A sanitary individualized method of drying hands shall be available at each lavatory. There shall be 1 bathtub or shower for each 8 licensed beds or fraction thereof. All bathtubs, toilets, and showers used by residents shall have approved grab bars securely fastened in a usable fashion. Privacy shall be provided at toilets, urinals, bathtubs, and showers. Toilet facilities shall be at or adjacent to the kitchen for kitchen employees. Facilities for handicapped persons shall be provided whether or not any of the residents are classified as handicapped. All bathroom floors shall be entirely covered with an approved non-absorbent covering. Walls shall be non-absorbent, washable surfaces to the highest level of splash. There shall be a mirror above each bathroom lavatory for residents' grooming. An adequate supply of toilet tissue shall be maintained in each bathroom. Easily cleanable receptacles shall be provided for waste materials. Such receptacles in toilet rooms for women shall be covered. Bar soap, bath towels, and washcloths shall be provided to each resident as needed. Bath linens assigned to specific residents may not be stored in centrally located bathrooms. Provisions shall be made for each resident to properly keep their bath linens in their room, i.e., on a towel hook/bar designated for each resident occupying that room, or bath linens to meet resident needs shall be distributed as needed, and collected after use and stored properly, per Section 1706. Exception: bath linens assigned to specific residents for immediate use may be stored in the bathroom provided the bathroom serves a single occupancy, one resident, room, or is shared by occupants of adjoining rooms for a maximum of 6 residents. A method that distinguishes linen assignment and discourages common usage shall be implemented. Doors 2. All resident rooms and bath/restrooms shall have opaque doors for the purpose of privacy. All glass doors, including sliding or patio-type doors, shall have a contrasting or other indicator that causes the glass to be observable, e.g., a decal located at eye level. Bath/restroom door widths shall be at least 36 inches wide. Doors to resident-occupied rooms shall be at least 36 inches wide. Doors that have locks shall be unlockable and openable with one action. If resident room doors are lockable, there shall be provisions for emergency entry. There shall not be locks that cannot be unlocked and operated from inside the room. All resident room doors shall be solid core. Resident room doors shall be rated and provided with closers and latches as required by the codes referenced in Section 1902. Ramps 2. At least one exterior ramp, accessible by all residents, staff members/volunteers, and visitors shall be installed from the first floor to grade. The ramp shall serve all portions of the facility where residents are located. The surface of a ramp shall be of non-skid materials. Ramps in facilities with 11 or more licensed beds shall be of non-combustible construction. 1. Ramps shall discharge onto a surface that is firm and negotiable by a wheelchair in all weather conditions and to a location accessible for loading into a vehicle. Handrails/guardrails 2. Handrails shall be provided on at least one side of each corridor/hallway. Exception: in facilities with 10 beds or less, handrails are not required for interior corridor/hallway. Screens 2. Windows, doors, and openings intended for ventilation shall be provided with insect screens. Windows/mirrors. The window dimensions and maximum height from floor to sill shall be in accordance with the building codes as applicable. Where resident safety awareness is impaired, safety, non-breakable, mirrors shall be used. Janitor's closet 2. There shall be a lockable janitor's closet in all facilities. Each closet shall be equipped with a mop sink or receptor and space for the storage of supplies and equipment. Storage areas. Adequate general storage areas shall be provided for resident and staff/volunteer belongings, equipment, and supplies as well as clean linen, soiled linen, wheelchairs, and general supplies and equipment. Storage buildings on the premises shall meet the building code's requirements regarding distance from the licensed building. Storage in buildings other than on the facility premises shall be secure and accessible. An appropriate controlled environment shall be provided if necessary for storage of items requiring such an environment. In mechanical rooms used for storage, the stored items shall be located away from mechanical equipment and shall not be a type of storage that might create a fire or other hazard. 1. Supplies/equipment shall not be stored directly on the floor. Supplies/equipment susceptible to water damage/contamination shall not be stored under sinks or other areas with a propensity for water leakage. In facilities licensed after the promulgation of these regulations with 16 beds or more, there shall be a soiled linen storage room which shall be designed, enclosed, and used solely for that purpose, and provided with mechanical exhaust directly to the outside. Telephone service. Supplies/equipment shall not be stored directly on the floor. Supplies/equipment susceptible to water damage/contamination shall not be stored under sinks or other areas with a propensity for water leakage. In facilities licensed after the promulgation of these regulations with 16 beds or more, there shall be a soiled linen storage room which shall be designed, enclosed, and used solely for that purpose, and provided with mechanical exhaust directly to the outside. Telephone service. At least one telephone shall be available on each floor of the facility with at least one active main or fixed-line telephone service available. At least one telephone shall be provided by the facility on each floor for staff members/volunteers to conduct routine business of the facility and to summon assistance in the event of an emergency. Pay station phones are not acceptable for this purpose. Residents shall have telephone privacy pursuant to Section 1001.L. Location. Transportation. The facility shall be served by roads that are passable at all times and are adequate for the volume of expected traffic. Parking. The facility shall have a parking area to reasonably satisfy the needs of residents, staff members/volunteers, and visitors. Access to firefighting equipment. Facilities shall maintain adequate access to and around the buildings for firefighting equipment. 1. Outdoor area. Outdoor areas where unsafe, unprotected physical hazards exist shall be enclosed by a fence or a natural barrier of a size, shape, and density that effectively impedes travel to the hazardous area. 1. Mechanical or equipment rooms that open to the outside of the facility shall be kept protected from unauthorized individuals. 2. If a swimming pool is part of the facility, it shall be designed, constructed, and maintained pursuant to our .61-51. 2. There shall be sufficient number of outside tables and comfortable chairs to meet the needs of the residents. Section 2700. Severability. 2701. General. In the event that any portion of these regulations is construed by a court of competent jurisdiction to be invalid or otherwise unenforceable, such determination shall in no manner affect the remaining portions of these regulations, and they shall remain in effect as if such invalid portions were not originally a part of these regulations. Section 2800. General. 2801. General. Conditions that have not been addressed in these regulations shall be managed in accordance with the best practices as interpreted by the Department.